Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's Editor-in-Chief, Dr. Eric Topol, and Master Storyteller and Clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
Hello, this is Eric Topol for Medicine and the Machine for Medscape WebMD, and I'm so delighted to have a chance to have an extended conversation with Fei-Fei Li, who is a professor at Stanford. She runs the Stanford AI Human-Centered Institute. She's had an enormous influence on the field of artificial intelligence over the years, and is a hero of mine, no less a real friend. So welcome, Fei-Fei.
Thank you, Eric. That was really kind, and the feeling is mutual. You're also a hero of mine in digital medicine.
Oh, you're very kind, and I know we're going to have a fun discussion because you've put a lot of thought into this human side of AI. So maybe we can start off. You recently, earlier this year, started a new institute across the whole Stanford University, and maybe you could go into the background of why you did that and where it stands.
Right. So you're referring to the Stanford Institute of Human-Centered AI. It's new in many ways, but it's also not new because at Stanford and elsewhere in the country, there is already a lot of research going on at the cross-disciplinary areas of not only AI technology, but the human side of understanding AI's social and humanistic impact, as well as the interdisciplinary collaborations with medicine, education, and many other fields. So this institute put together all this at, I would call, a critical moment in history where for the first time in this decade, we are seeing this niche field of computer science called artificial intelligence making its way into real life, and its impact on human lives and society just exploding through the tremendous potential in its applications and products and services in every sector of the industries. I think it's really important we understand how to guide this technology forward, both in terms of its science, but also in terms of its applications and impact in human lives.
Well, there's no question the issues of AI influencing our lives are bigger, of course, than medicine, and that's why it's so appropriate you're leading this charge with this institute. Now, you started something that changed the field over time many years ago called ImageNet. And a lot of the folks in medicine are not aware that that was kind of the precursor to what is, of course, the big things that are going on in medicine today with respect to scans, all the different types of scans, and whether it's eye grounds of the retina or whether it's electrocardiograms or anything that's an image in medicine. But in many ways, it started back when you began ImageNet. So can you tell us about what was going on in your mind back then and what that led to in the field of deep learning?
Yeah, sure. I'll be brief. So my sub-area of specialty in AI is at the intersection between computer vision and machine learning. Back in 2006, I was, along with the field, working on very important and a holy grail problem of vision, which is what we call object recognition. If you think about intelligent animals like humans, we see the world in very rich ways, but a building block of our visual intelligence is recognizing tens and thousands and hundreds of thousands of different kind of objects that's around us, be it cats, trees, chairs, microwaves, cars, pedestrians. So enabling machine intelligence with that capability was a holy grail, still is, and our field was working on it. And I was a young assistant professor. It was my first year of a faculty job. I was looking at this problem, and it dawned on me that while we were working on all these machine learning algorithms of that era, of that generation, we were, as a field, playing with this very small set of data of, a couple of dozen object classes. The data sets have about 100 or at most a few hundred pictures per classes, and it's just such a sharp contrast to the real world that humans and animals experience. So we were inspired by human development and recognized that there is a huge need for big data to drive learning. It not only drives the diversity of the different patterns, but more mathematically important, it helps any learning system to learn to generalize better instead of overfitting on a much narrower set of data patterns that do not generalize to the big world. So with that recognition, we just thought we'll do something crazy, which is which is really to map out the object world of the entire the world around us. And how do you go about it? We were inspired by the biggest English vocabulary taxonomy that was invented in the 1980s by a linguist called George Miller. It's called WordNet. WordNet has more than 80,000 nouns that depicts the world of objects. So we took at the end 22,000 object classes, downloaded from the internet through different search engines, and launched a massive crowd engineering project through Amazon Mechanical Turk, which was in its first couple of years of offering as a business. We got more than 40, 50,000 online workers from 160 plus countries to help us clean up and label almost 1 billion images, and ended up with a very curated data set of 15 million images over 22,000 object classes.
That's
and
amazing.
that became ImageNet.
Yeah.
And we immediately open sourced it to the research community. And starting 2010, we held an annual international competition called ImageNet Challenge to invite worldwide researchers to participate in this, solving this holy grail problem of computer vision. And a couple of years later, machine learning researchers in Canada used a fairly traditional model called convolutional neural network to win that ImageNet challenge, and that's the year 2012. That was Professor Jeff Hinton's group, and I think many people consider that work on ImageNet challenge the kind of the milestone work for the start of the deep learning era.
Right, and they just were awarded earlier this year the Turing Prize, like the Nobel Prize for Computer Science. So
yes.
you set them up, though, Fei-Fei.
Thank you for the recognition.
Back 4 years ago, you gave a TED Talk about how we're teaching computers to understand pictures. I think a few million people have watched that. It's just extraordinary. And I remember asking you about it, and I think in that you show a statue of a man on a horse, mm-hmm. and how computers can only get so good. I mean, there's a big gap of context. And so a man on a horse, even though basically the miscues that still occur, I remember asking you about that. We have only gone so far, right? I mean, is that a fair statement about how we can train machines to interpret images?
Yeah, so despite the fact that our field since has been steadily making a lot of progress, you're totally right. There's a lot of nuance, context, rich knowledge, common sense, reasoning. All this is still um, escapes today's machine intelligence. And in the field of vision, a statue like man on the horse might still escape machine recognition. And even if we overtrain a system to recognize sculpture, let's say, it still does not recognize it in the same way that human intelligence does, treating it as an art piece, understanding the context, recognizing its material, and all those rich details are still missing.
Right. Now, another part of the story in medicine is that there's a limited number of these annotated data sets. There is no ImageNet with 15 million carefully annotated images. So the same data sets just keep getting used again and again. You want to comment about, are we going to rely, do we need to have a kind of a dedicated effort to develop these data sets, or are we going to move to some kind of self-supervised, unsupervised learning?
Great question, Eric. I think the answer is definitely, as you know, probably multi-pronged approach. It's a common frustration of researchers and developers in medicine in terms of the lack of a good aggregated data set in many cases. But there is good reasons, right? Medical data needs to be much more carefully curated for reasons of patient privacy, safety, and we also have much more awareness of the issues of bias that comes from data. It's okay to make cat images biased, but it's really not okay when it comes to human lives and health and well-being. So all these reasons and regulatory constraints make it a lot harder for medical data to be aggregated in a massive way. I do think good-hearted efforts needs to be made, and I know researchers around the world are doing different efforts. Some are joining force. In the meantime, the technology itself can contribute in different ways as well. So in addition to the need of good data sets and training supervised learning algorithms, like you said, machine learning field has been making a lot of progress on these very interesting newer techniques like self-supervision, transfer learning, federated learning, unsupervised learning. So I think we're going to see a mixture of approaches. Some cases we still need good data sets. Some cases much more multimodal and mixed data sets can make a lot of headway.
Right. I guess since the first big wave of work has been in medicine, certainly in the image side, and we're starting to see these synthetic notes based on a conversation between patient and doctor to eliminate a keyboard potentially.
Right.
And that's exciting because that's kind of the common enemy of both patients and doctors and clinicians in general.
Yeah.
So you'd be optimistic that eventually we wouldn't have to use data entry clerks, that is clinicians, to do that work?
So that's specifically a specific area, Eric. I actually 100% agree with you. I'm not only optimistic, I really hope that we will take off as much mechanical charting burdens from our clinicians as possible because of the work we do in healthcare, as well as, just taking care of my aging parents. I spend a lot of time in hospitals and observing work by our nurses and doctors. I think one of their number one wish to people like me and my field of artificial intelligence is, can you give me back more time to attend my patients rather than watching a screen and charting? So I really hope, whether it's for the sake of patients or clinicians, or even economic point of view, will see progress being made in that area.
Yeah, and I'd really be interested to learn about your direct experiences. I know you've cared for your parents and they've had medical needs. What has been your experience as a family member of patients undergoing care as it exists today, even in first-rate medical centers?
Yeah, so first of all, as a family of patients, the human experience of anxiety, fear, hope, all this is still predominant. One thing I think it really helped me to believing what I do is having that personal experience. I'm such a firm believer that technology is here to augment and enhance human work, not to replace. And this is a big theme in my own research, as well as in Stanford's HAI Institute. Especially in the field of medicine, we've heard a lot of talks about replacing doctors because there are machines doing, say, better diagnostics and all that. But having experienced those medical, full set of medical experience, from surgery to ICU to extended hospital stay with my aging parent, I cannot even begin to imagine a world of no nurses and doctors for our patients. Healthcare at the end of the day is humans caring for humans. But what made me feel so convicted and strongly is that if technology can play that supportive role to, like help charting, to improve triaging by faster early diagnosis, to serve as an extra pair of eyes to ensure patient safety, all this would be so useful. And that's what I'm working on and I feel very passionate about.
You can read the transcript from this podcast and find more Medicine and the Machine episodes at medscape.com/machine. Medscape news, features, clinical tools, and education are available for free. Stay on the pulse of medicine. Visit medscape.com.
You've collaborated a lot with Arnie Milstein there, and you've been doing a lot of work, for example, I guess in machine vision, in the intensive care unit, and maybe you can tell us about some of that great work that you've been tackling.
So about 7-8 years ago, Arnie and I, Arnie is Dr. Arnold Milstein is a professor of medicine at Stanford and also a national thought leader in thinking about how to improve healthcare quality, but also curtailing healthcare cost from different angles, from research to policy to business practice. And we kind of met serendipitously and recognized a very interesting moment. I, as a AI professor, was seeing that deep learning age coming, especially through the lens of self-driving cars, where the advances of smart sensors, AI algorithms, and then lowering the cost of all these enabled a whole different technology that is much more pervasive, ambient, and can enable transportation technology in a way that's very different from today's cars that mostly rely on human drivers and so on. So when Arnie and I started discussing that technology and comparing notes and look at in healthcare delivery system, moments of errors, the big gaps of lack of enough human care to ensure patient safety, the need to optimize human more effectively so that we can give human clinicians the quality time back to patients and help them to do their work. All these opportunities converged with this new technology of smart sensors and AI algorithms. So we start talking about health critical scenarios in our healthcare delivery system and how we can prototype smart sensors for helping. So one area we identify is ICUs, and there are just many, many things that makes ICU really critical, right? Our patients are fighting for their lives. Our clinicians are working intensely every single minute. Yet, if there's any error made or negligence or just honest mistakes can cost lives. So we start talking to Intermountain Hospital in Utah as well as Stanford Hospital and see if we can pilot a project on patient care in ICUs and help clinicians document if proper patient care like oral care or mobility care are being done according to protocols because of the nature of the busy work in healthcare. So in this particular project, we installed cheap depth sensors that can collect human behavior data on patients and clinicians without infringing on their privacy, because these are not photographs of people's faces and identities. But with that information, we can observe longitudinally 24/7 what are the proper care being given to our patients and give feedback in the health delivery system. The same thing is happening in Stanford Children's Hospital, where we are piloting the hand hygiene project, because we know proper hand hygiene prevents hospital-acquired infections that costs thousands of lives every year in America. And they're, again, using these cheap sensors and deep learning algorithm, we can map out clinicians' hand hygiene behavior and begin to send back that feedback signal to remind them to perform proper hand hygiene that was established by WHO as a protocol.
Well, yeah, it's actually far-reaching how many things you can tackle with these sensors and machine vision to promote safety and better outcomes for patients in the hospital. And I noticed that with the opening right now with the Stanford new hospital, you have dedicated beds for AI. Is that right?
Yeah, so we are definitely very early. We're collaborating with the hospital where we will scale up this project of sensors. And it's very early, so we have no results to discuss, but it's supported by clinicians, hospital leaders, AI researchers. And one thing that also excites me is that we are also looping in ethicists, law scholars, bioethicists to talk about all the frontier challenges that come with this technology research. And we want to stay on top of that and be very mindful to make sure our patients and clinicians and families or stakeholders feel safe.
Now, one of the things that, of course, is important for implementation of AI in medicine is for doctors and clinicians to have a comfort level, to understand the nuances, some of the issues that we've already touched on. The group that I know, led by Pierce Keane in the UK, they published a paper where they took doctors who never written a line of code, who had no background in computer science, and they worked with image sets, and they learned, a lot about being able to get image interpretation accuracy. Do you think that that's a good idea for, even though obviously we're not going to get doctors to develop the algorithms, to have more familiarity with them?
Yeah, so Eric, I'm not particularly familiar with that particular project, but this general issue in our work about how to work in a very interdisciplinary group setting and how do we bring doctors and computer scientists on board is something I've been experiencing for the past 7-8 years. And I think it's a fascinating journey. I'm still learning, but one of the most important things I've learned really is to spend time with each other and understand the nature of each other's work, their concern, their value proposition, and really have that patience and open-mindedness to embrace each other's field. And it's not going to be a linear process. I remember the early days of the computer science team and the clinician team in our research team talking past each other. Even till today, when new students or new members got brought on, there's gonna still be multiple meetings where we talk past each other.
Right.
And we, for as a computer scientist, one requirement I have for my computer science students joining our AI and healthcare work is they absolutely have to shadow doctors and nurses before they even talk about codes and algorithms. They need to go into the ICUs or the ward or the surgical room or the senior home to understand that human working condition and the patients and their families, spend enough time, and then we begin talking about the computer science project.
Well, you just nailed it. The other thing that you do, which is among your pluripotent contributions, is AI for all. So you're not just trying to get the computer scientists to work with the clinicians, but you're also trying to develop the next generation of computer scientists. So tell us about AI for all.
Thank you so much, Eric, for bringing that up. So, so AI for All started more than 5 years ago now. And again, that was around year 2014. We're in the very early days of deep learning revolution. And the whole world, especially tech and Silicon Valley, was just lighting up with excitement and also debates and concerns about this technology. And I literally just kind of woke up one day and realized there's a disconnect between, on one hand, people worrying about Terminators coming next door, how the machine overlords and all that. On the other hand, I live personally every day in a world of no diversity. My world, my professional world of artificial intelligence has very few women. Most of our technical conferences have less than 15% women. And if you look at underrepresented minority, we don't even have good stats because the number was and is still so small. So I made a connection that these two things are actually deeply, profoundly connected. If we, as a human species, society, care about the future of our society due to this technology, we've got to care about who is shaping this future. If a very narrow slice of humanity is the only representation in shaping this technology and at the steering wheel, we're really gonna run into a danger of this technology not representing all of us. And with that realization, then I had a wonderful former PhD student who, at that time, she was still at the last year of her PhD study, Olga Rusakovsky. She's now a Princeton professor in AI. She and I just talked about our concerns, and we completely hit off, and we said we need to do something. So for the first couple of years, 2015, 2016, we just piloted a program at Stanford where we invite high school women to come and study and research on AI with us for a few weeks in the summer in the AI lab. And that program became so wildly successful in 2017 with the encouragement of Melinda Gates, Jensen Huang. We launched the national nonprofit called AI for All. And our goal, our mission is to educate and inspire the next generation AI technologists and thought leaders of all walks of life. So till now, AI for All is 3-year-old. in 2019 summer, we have expanded to 11 universities in North America for summer programs facing underrepresented minority students and underserved communities such as racial minority, low-income family students, rural students, and women. And we're still expanding, and our goal is really to move the needle in 10, 15 years when these students come out of their studies and will make a difference in the field of technology and AI. And we're seeing some early examples already.
The reason you became my hero I was doing my research for the Deep Medicine book is because I learned from the leaders of the field. Obviously, you're one of them. There's a whole range of how things get presented, from the contrarians to the masters of hyperbole. And what I've always adored about you, Fei-Fei, is you are the right balance. You kind of, you call it as it is. You're a seeker of truth, and you really kind of lay out the shortcomings. And I wanted to get your perspective, because obviously this is a field that's gone through its winters, and it's always, every week there's some big thing coming out, one, whether it's AI in medicine or even beyond that, of course. Where are we in the cycle about hyperbole and reality for AI, and especially as it pertains to medicine?
Yeah, this is a great question. Some people call this a bubble, but some people think this is so real. I think we're in a bubble wrap. Meaning that there is a solid core, which I see this technology as has really solid potential of impacting healthcare medicine in deep, deep ways. But there is a bubble wrap, that the hyperboles and the hypes and all these excited talks. So my hope as a scientist is the bubble wrap will burst. We'll focus on really making sure the solid core grows. That is in the benefits of all people. What I really want to make sure, especially in an area like healthcare and medicine, right? Like, we should not use technology to create injustice, to create bias, to amplify the existing inequity. I would love to increase access, increase fairness, and reduce all these issues because of this technology. And there is opportunity if we do it right. But we need to really be traversing both the human part of this technology as well as the technical core itself.
Well, Fei-Fei, really, thank you so much. This has been so enjoyable, a great opportunity to get your read on this whole thing, and I really appreciate it. And we'll continue to follow you for all the things that you and your team are doing.
Well, I continue to literally follow you and hear all about the digital medicine news and thought leadership from you. Thank you, Eric.
Thanks a lot.